All right, welcome everyone. Thank you so much for joining us tonight. We are going to wait a few seconds to get started, to let everybody in. All right, looks like we got a good amount of people. You'll notice as you log in, your mic and video are muted. They will stay that way, but we encourage you to ask questions in the Q&A down there, and then comments in the chat. In the meantime, hop over to the chat, give us a greeting, and let us know where you're tuning in from. Our speakers today are joining from Kentucky, Florida, New York, and Chicago. I'm in Seattle. Awesome. Looks like we got Clinton, Maryland. All right. Central Coast, great. We got California as well. Hello, hello. Okay, let's get started. I see our logins are plateauing. My name is Sak Paltan. I am the program director for the National Pancreas Foundation. One of our programs I oversee is our Black African American Initiative, where our main goal is to raise pancreas disease awareness among our African American community. If you want to get involved, please send me an email. I'm going to put it in the chat. We'd love your help. Just a few notes. This webinar is being recorded, and all registrants will get an email with the YouTube channel link by the end of the week. Tonight's webinar is titled Pancreas Disease and the Relationship Between Health and Faith. Tonight we are joined by some amazing speakers. I'm going to hand over the mic to Dr. Darwin Conwell, who is professor and chair at the Department of Internal Medicine, as well as the Jack M. Gill Endowed Chair in Internal Medicine at the University of Kentucky. He was part of the NPF Board of Directors as well. Dr. Conwell is an international authority on pancreatic disorders and a champion of diversity, equity, and inclusion. You'll be able to see that when he speaks tonight. He is an advocate of community engagement and health equity and a leading principal investigator on 5 NIH grants. This man is busy. Fun fact, he has been with the NPF since it started from Jane Holt's kitchen over 25 years ago. We're so lucky to have him tonight. Thank you, Dr. Conwell, for your support to the NPF and moderating tonight.
All right, thank you, Paul. This is really exciting for us. And what I say here at the University of Kentucky, it's another great day at UK. It's a great day for us to be in this webinar talking to you about pancreatic disease in the Black African American community. So I'm going to share my screen with you. We definitely want to thank AbbVie, our corporate sponsor, who has been really supportive of all these efforts, and we just can't thank them enough for what they are doing to help us bring this webinar to you. Let's make sure my screen is showing here. You all can see my screen? Give me a thumbs up, Jim, or anyone? Great. Okay, we're gonna go ahead and get started. So as I said, welcome to this next installment of our Black African American Initiative webinar series from the National Pancreas Foundation. In the United States, racial and ethnic inequities in health remain substantial, pervasive, and persistent over time. Social determinants of health, where we eat, where we live, sleep, play, and tonight we're going to talk about where we worship, has major implications on our health outcomes. So tonight is going to be pancreas disease and the relationship between health and faith. Today we're going to focus on the role of faith-based organizations as resources for tackling major health challenges and improving population health. And the National Pancreas Foundation recognizes the great opportunities to partner with the Black church to reduce and ultimately eliminate health disparities. Black church has been the long-standing institutional backbone of the African American community. It's been a focal point of hope and spiritual guidance and social supports for Blacks and African Americans for many, many years. The Black church has spearheaded advocacy efforts for political and social justice while providing health and other services for the disadvantaged communities it serves. Since its inception, the Black church has been a place of refuge and healing for the oppressed and marginalized, and remains a gateway to reach and mobilize Black African Americans for meaningful change and reform. Again, we want to thank AbbVie for their corporate sponsorship. We are excited to have you here with us today as the NPF Black African American Initiative continues its national campaign for healthcare equality throughout the Black community. We're excited, and we're going to go ahead and get started. I want to introduce my first guest is Dr. Cemal Yazici. I'm very excited to have Cemal here. He is at the University of Illinois, Chicago. He is a physician scientist, and he has a very large cohort of patients that are Hispanic and Black African Americans, and he is a thought leader in pancreatic disease. He is a NIH-funded investigator with the T1, the APC, which stands for Type 1 Diabetes and Acute Pancreatitis Consortium. We are very excited about the advocacy and what he is doing to address social determinants of health. And Dr. Yazici, the stage is all yours. Thank you very much for being here tonight.
Darwin, thank you so much for nice introduction. And here, I'm gonna share my slides. Is everyone able to see my slides?
Yes.
Okay, awesome. So I would like to start by thanking the NPF for giving me the opportunity to talk about pancreatic diseases, but more importantly is also starting the African American Initiative, and also to Dr. Conwell for leading the initiative and making sure that this topic is discussed in appropriate platforms when we come together as physicians and scientists. So today I will see here. I will provide a brief outline and start with health inequities, which is slightly highlighted by Dr. Conwell here already. I will go over the functions of pancreas and briefly talk about the spectrum of pancreatic diseases. We'll review some of the symptoms and signs. We'll touch on social determinants of health in pancreatic diseases, which also includes diet and nutrition, and how we have done in the past so far in regards to inclusion of Blacks and African Americans in pancreatic disease studies, and what we can do in order to increase their enrollment in such studies. So racial and ethnic minorities are at increased risk for developing acute pancreatitis and also other pancreatic diseases and pancreatitis-driven complications. These include diabetes and pancreatic exocrine insufficiency. And especially African Americans, they are 2 to 3 times more likely to develop acute pancreatitis compared to whites. They have higher rates of pain and disability due to pancreatitis than any other racial ethnic groups. They are less likely to be transferred to tertiary care centers for a higher level of care. And they have the highest incidence rate of pancreatic cancer among all ethnic and racial groups in the United States. If you look into the spectrum of pancreatic diseases, you can see that big circle that includes acute pancreatitis, whether it's gallstone-induced or other causes of acute pancreatitis. A subgroup of those patients develop recurrent attacks. We call it recurrent acute pancreatitis. And portion of those patients, if they have these repetitive pancreatitis attacks, acute pancreatitis attack, they can subsequently develop chronic pancreatitis. And at the bottom towards corner, you can see the relationship between chronic pancreatitis and pancreatic cancer. So this slide from Dr. Yadav really shows that how these pancreatic diseases are related to each other. And pancreas has 2 key functions. Exocrine function, it secretes digestive enzymes that are needed for breaking down the nutrients. And endocrine function, it secretes hormones such as insulin and glucagon. And pancreatic disease, therefore, can affect exocrine function, endocrine function, or both. Acute pancreatitis, this is the inflammatory disease of the pancreas, can lead to pancreatic injury. And the degree of this pancreatic injury really depends on the severity of acute pancreatitis attack. If a patient has recurrent acute pancreatitis attack, this can lead to damage. This can further damage the pancreas and in long term lead to pancreatic scarring and tissue destruction and subsequently progress into chronic pancreatitis. And therefore, pancreas can lose its ability to perform its endocrine and exocrine functions. And patients in the spectrum of pancreatic diseases can present with a variety of symptoms. And usually the most common symptom, the worst one that brings the patient to the healthcare facilities is pain. Especially in acute pancreatitis, it's acute onset, persistent, severe abdominal pain. And when we examine, usually we note that it's located in the epigastric area. Patients often report that it radiates to back. It can be associated with nausea or vomiting or bloating. And oftentimes, because of vomiting, these patients are also very volume depleted. Therefore, they may have weakness and fatigue. They may have fast heart rate. And if they develop severe acute pancreatitis, this can lead to collection of fluid in the lungs or around the lungs, and this can lead to development of shortness of breath. And pancreatitis at times can also associate with infection. If that's the case, patient may feel warm. And depending on the etiology, especially if it is a gallstone-related pancreatitis, and if the gallstone gets impacted within the common bile duct, it can cause a blockage and lead to yellowing of the skins and the whites of the eyes. So that is called jaundice. So patients can sometimes have jaundice as well. While most of the patients with mild acute pancreatitis, that's approximately 75 to 80%, they do relatively well. Within a day or two, they start to feel much better and get discharged from hospital. Those with moderately severe acute pancreatitis, they stay in the hospital longer. They usually have either a transient organ failure that resolves within 2 days or local or systemic complications. But the last group, the ones with severe acute pancreatitis, those that develop organ failure are the ones actually that do the worst. They are the ones most often who goes to intensive care unit and have a really prolonged hospital stay with many complications that require interventions. So if you move into chronic pancreatitis, again, chronic pancreatitis, so patients also have abdominal pain. Again, it can be quite severe, but usually it's constant. Sometimes patients get some relief from this pain, but it comes back. And again, it can be associated with nausea and vomiting. And because of this pain, they sometimes have fear of eating. Because it's associated with worsening pain. Therefore, they have really decreased food intake. They may have bloating. If they develop pancreatic exocrine insufficiency, they may have diarrhea or oily stools. And also in long term, this leads to development of weight loss. If they have a really bad disease with structuring that is usually around the head of the pancreas, then they can also cause blockage of the bile duct and lead to development of jaundice. We move to pancreatic cancer. Pancreatic cancer patients also have pain, but with any other cancers, they also have decrease in appetite and significant weight loss. And they can develop the jaundice as well, and also may have light-colored or floating oily stools with dark-colored urine. They may experience itching, nausea, or vomiting. And unfortunately, management of pancreatic diseases, especially the pancreatitis, is limited at the moment. We do not have any proven pharmacological therapy that we can offer to acute pancreatitis patients. So we try to focus on maintaining the volume studies, especially when our patients present early during their hospital admission. And we really try to optimize the nutrition. It's crucial for both acute and chronic pancreatitis, as well as pancreatic cancer. The pain control is another important step. While we try to control the pain quite well at the beginning with a little more strong pain medications during initial admission, then we try to titrate them down for acute pancreatitis, while chronic pancreatitis patients need more longer outpatient management of their pain. Since These patients develop local and systemic complications. We pay a lot of attention to recognize them early on and provide supportive care and therapeutic interventions to address these complications when they develop. Another important step here is prevention of recurrent attack. Especially this happens quite often in gallstone pancreatitis if the gallbladder is not removed. So anytime we have a gallstone pancreatitis patient that we know that there are gallstones in the gallbladder, we recommend that that gets removed during hospital admission. And we also obviously counsel our patient in regards to decreasing the risk of recurrence, especially if it is related to smoking and alcohol. And for pancreatic cancer, it's very important to diagnose it early on, refer it to centers of expertise for timely evaluation and treatment. So from here, I will cover two other important topics that develop following pancreatic diseases. One of them is exocrine pancreatic insufficiency. It's a deficiency of pancreatic enzyme production following acute pancreatitis or chronic pancreatitis. It results in intestinal malabsorption and can lead to gastrointestinal symptoms and increase the risk of malnutrition. In the past, it was a lot more often associated with chronic pancreatitis, but we know right now that even acute pancreatitis patients, even after a single attack, they can develop exocrine pancreatic insufficiency. And because of that reason, they are at risk for developing vitamin and mineral deficiencies. And in long term, this can reflect as night blindness related to vitamin A, especially the bone problems, osteopenia and osteoporosis because of vitamin D deficiency, bleeding complications, as well as anemia. The other important long-term outcome of pancreatic diseases is development of diabetes. This is a diabetes related to pancreatitis. So new onset diabetes in chronic pancreatitis is known for a long time, but lately we recognize that even acute pancreatitis patients after a single attack can develop diabetes mellitus. It's mainly related to destruction of beta cells that produce insulin. But lately, immune mechanisms have also been proposed to play a role, and there are studies looking into this right now. And more interestingly, even those patients who have very mild attack of acute pancreatitis can develop diabetes. And we know that diabetes itself is already a major healthcare problem with a disproportionate burden in African-American communities. And on top of that, if we have pancreatitis-driven diabetes, this further increases the burden of diabetes in our communities. And we have unique opportunity that presented itself several years ago to study the impact of pancreatitis-driven diabetes in now NIH-funded prospective observational acute pancreatitis study. And Dr. Conwell and are part of that study and trying to further understand this mechanism. And from here, I want to touch on social determinants of health. These are the non-medical factors that influence health outcomes. As Dr. Conwell highlighted, these are the conditions in which we were born, we work, we grow, live, and the wider set of forces and systems that shape the conditions of daily life. And these forces include economic policies, development agendas, social norms, racism, climate change. And if you look at this figure, you can see that one of these arms is social and community context. And we think that faith-based organisms really fit into this social and community context really well, and in fact are key social determinants of health variable. And as a field and physician scientists, when we see a patient with pancreatitis, we mainly focus on identifying the cause. And they are listed under the proximal factors here. We are trying to see if it is because of a metabolic problem, if there is an anatomical abnormality, if there is anything related to genetics. But you can see that there are other intermediate factors and distal factors. And social determinants of health actually fall into this category. And it includes many variables that we all have in our daily lives, from physical activity to education level, to household income, to social network and engagement, to safety, to residential zip code, to diet availability. So these are really key factors, and in fact are related to many disease outcomes. And here at Chicago, our institution is located in a minority serving area. So majority of our patient population, close to 80–90%, are actually minorities. And we look into these factors, and this is just a preliminary data I try to summarize that shows that minorities, and this is predominantly African-American patients, have significantly higher social vulnerability compared to Caucasians, even those with acute pancreatitis. So it is really a significant phenomenon that we know. And one of these key social determinants of health variables is actually diet. And diet plays a really key role in pancreatitis and pancreatic diseases, that's all. So it's really important to customize and really focus on nutrients-dense food and beverage choices, and limit the foods and beverages that are higher in added sugars, saturated fats, sodium, and alcoholic beverages as well. And when we say that nutrients-dense foods, they provide vitamins and minerals, those that we can potentially lack because of pancreatic exocrine insufficiencies, that they have other health-promoting components, and they have very little added sugars and saturated fat and sodium. So these include vegetables, fruits, whole grains, nuts, fat-free and low-fat dairy products, and lean meats and poultry. And from here, I will conclude with this last section, and I wanted to show the underrepresentation of minorities, especially African Americans, in pancreatic disease studies. You can see that some of them are really large studies, reaching up to 7,000, 8,000 patients in studies, and focusing on acute pancreatitis and chronic pancreatitis, looking into the natural history of disease, the role of alcohol and smoking, pancreatic exocrine insufficiency, fluid, and also physical mental health. And some of these are really from our colleagues who are really pioneering the field, really trying to contribute to the field. But unfortunately, you can see that majority of these studies are done predominantly white cohorts, reaching in average 85%. So we only have 15% minority representation, and African Americans are only small, or maybe some part of it. So there is a significant knowledge gap here, and also need for increasing their presence in these pancreatic disease studies. So what can we do on our end? At least here in our institution, we are trying to focus on these teams to increase their participation, try to have diverse cultural component study teams so we can better connect with our patients. We try to engage our patients early on. Really, you need to put the time and really show your empathy. And we also try to involve in this process as physicians. It really helps to establish the trust with patient. We discuss all these important components and really highlight the need for their enrollment. And if we do that, and we can really empower the patients to be a part of the change, I observe that is really well taken and really motivates patients to participate. We are trying to provide flexibility as well as engage our communities using our community engagement boards. And we are trying to also address barriers and social determinants of health to keep them engaged. I think with that, I will end, and I'm happy to take any calls. Thank you.
Thank you, Dr. Yazici. We're going to hold questions to the end, and please enter your questions in. Feel free to type a long list. We'll be happy to answer those. I'm now going to move on. I have the privilege of introducing our next speaker, Pastor Bradford, Pastor Crystal Bradford. who is a licensed and ordained minister in the office of pastor teacher. She has a passion for helping people during seasons of transition so they can move forward. In October 2019, she relocated to New York City from one of my other favorite cities, Chicago, Illinois, and was connected to the Choose Healthy Life program in the fall of 2020. She's a champion for change in the area of health and wellness, and we are just excited that she is here. She is married to Pastor James Bradford, and they have 4 children and 1 son-in-law, which I really like that terminology, and 2 grandsons. She's a member of Christ Fellowship Baptist Church, where she serves under the leadership of Reverend Dr. David L. Kelly. And I want to also mention that she is a health navigator, so she's really informed and is taking it to the people, and we really are excited to hear what she's got to say. So, Pastor Bradford, thank you for being here.
Thank you so much. So excited to be here with you all this evening. Give me just a moment to share my screen here. Wonderful. I am excited to share with you all for just a few moments about the relationship between health and faith. Dr. Conwell gave us a very great intro about the deep roots of faith in the Black community. I love the things that he shared at the beginning of our presentation this evening. The pastor in the Black church wears many hats. He is in a lot of ways an extended part of the family. He welcomes the new babies. He celebrates milestones with the families, graduations, marriages, oftentimes even having dinner in the homes of his families. When misfortunes happen, he's there to help the families manage those moments, to help them to navigate the twists and the turns of transition. And when death occurs, it is the pastor who's called upon. He's there to comfort the families. He's there to mourn with them, to give them guidance and assistance during those sorrowful times. It was that frame of reference that the Choose Healthy Life was founded upon. Our founder, Deborah Fraser Howe, founded Choose Healthy Life program in October of 2020. It is a nonprofit organization focused on establishing a sustainable, scalable, and transferable approach to address public health disparities through the Black church. She founded Choose Healthy Life in response to the COVID-19 pandemic after seeing the disproportionate death and inequitable health impact that it was having on the Black communities. She saw an opportunity, crisis. I believe that we can see crisis as a giant problem, or we can see crisis as an opportunity. And she saw this as an opportunity to bring faith and medical science together by establishing a trusted health workforce within the Black church to connect hard to reach and underserved communities on the ground to much needed health services. She also formed a panel to help oversee. On the faith side, we had the National Black Clergy Health Leadership Council that is comprised of pastors in various cities. It is co-chaired by civil rights leader Reverend Al Sharpton. And on the medical side, we have the Medical Advisory Board with several members, of which are Tom Frieden, former CDC director under President Obama. We have Dr. Lewis Sullivan, former HHS secretary under President Bush, and Dr. Donna Christensen, who was a member of Congress from 1997 to 2015. CHL, Choose Healthy Life, had began in 5 legacy cities: New York, Newark, Detroit, Atlanta, and Washington, D.C. When our pastor was approached to become a part of this, he felt like this was an opportunity to not just help our congregation, but to help the community at large. You know, it was the Choose Healthy Life program that provided resources during the most intense parts of the pandemic. I like this phrase that says that CHL is not just a name, but it is a call to action. Our people were in need of help, and we were mobilized to provide it. The program called for each church to identify a person who would be the health navigator. For our church, I am that person. I was then charged to form a team, and my team, along with our pastor, was equipped to bring much needed medical resources right to the church in the heart of our communities. Through the Choose Healthy Life program, we were able to get food. You know, during the heart of the pandemic, food was in need. So we were able to give out bags of groceries. We received funding that allowed us to have PPE. Here in New York, the Department of Health sought out Choose Healthy Life churches and allowed them to offer much needed COVID testing. After the vaccine was developed, we became sites where the vaccine was administered. Pastors in many of the churches were right there on site to assure members during those challenging times that the vaccine was safe. You know, that was a big question in many of our communities. I want to just say that, you know, trust relationships are seldom formed during crisis. Therefore, it is necessary to partner with relationships of trust that are already secure. These connections, the connections between the pastors and their congregation, between the Black churches and the community, and between the members of the community at large, these connections had already been tested and tried in crisis before, and they had been proven to be trustworthy. So it was very wise to tap into these already trusted connections during the pandemic. Once COVID began to wane down, problems were revealed that could no longer remain hidden. It was clear that our communities had underlying causes that caused us to be more at risk, that caused the death rates in our communities to be higher than other ethnic groups. Because Choose Healthy Life was already a viable framework, we were able to then build upon this framework that had been established during the pandemic. We pivoted our efforts and then began to address those underlying conditions. We began having health fairs, as you see in these pictures here. We were charged with connecting with hospitals and clinics in our community. For us here in Brooklyn, New York, New York Presbyterian Hospital became a site that allowed us to tap into the resources that they had. They came right to the church. We also, Memorial Sloan Kettering Cancer Center, their tent is a little bit back in the back. I'm not sure if you can see it there, but they've got the blue tent there in this picture. But these hospitals and clinics then began showing themselves in the churches. People didn't have to go out they could come to that trusted place and begin establishing those connections that before COVID they didn't have. It became important for us to help our community understand that going to the emergency room does not replace having a primary care physician. We began to address the social determinants of health and then connect our people with much needed resources. Quest Diagnostics was a partner for us and still is, and they offered something called the Blueprint for Wellness. It is a complete diagnostic screening. As you can see here on the screen, it screens on the slide here, it screens several areas of health through blood testing. They're doing this right in the churches, and people are able to get results from these blood tests to help guide them. As we pivoted our efforts, each church was then tasked with having weekly health and wellness seminars. We began to have fitness classes right there in the churches. Pastors in there exercising with their congregations, and people just learning to do things better. We began having food demonstrations, helping people to learn to cook healthier, that you can cook healthy and still enjoy your meals. We have weekly health and wellness sessions. We have monthly, at least in our church, we have monthly, what we call Super Saturdays, where we invite other community-based organizations to come in. We have people from the hospitals that come in and just give seminars and webinars on topics that are of need for our community to learn. As far as the social determinants of health, we also know that these social determinants of health impact the health and wellness of our communities. So along with having webinars and sessions on healthcare, we also have mental health webinars. We also have sessions on finance, because if your finances are stressful to you, it can impact your health. So these are all areas that we began to address right inside of the church. The Choose Healthy Life program has now expanded and is now a nationwide program. And so we are really looking forward to having more impact on our communities as we connect the faith component and the health component. We're also, I want to mention this as well, we're also going out to offer sessions in community centers, in the senior citizen centers. As you can see here, this was at a local community center, and the National Pancreatic Foundation provided us with some slides and some gear that we have here on the table. We had a slideshow that was set up there, and people were able to just come and learn more about pancreatic disease, pancreatic cancer, things that they can do proactively to take care of themselves. I hope that this has been informative to you. I hope that you know a little bit more about Choose Healthy Life. When you see that logo, CHL, you'll know that we're doing great things in the community, that you can choose life. You can choose to do better. And now I'm going to turn it back over to you.
Well, thank you very much, Pastor Bradford. This was very inspirational. I'm really excited about the Choose Healthy Life program and really expanding that across the country and partnering with the National Pancreas Foundation. We definitely want to hear more about that in Lexington. I'm going to introduce Leesha Archie. We have a treat tonight. Leesha Archie is a mother, media influencer, on-air radio personality for Praise 107.9. She's a 20-year veteran of the entertainment industry and founder and CEO of Leesha Archie Enterprises, LCC. And what she's going to say tonight is going to impact hundreds and thousands of lives, and you will see why in a few minutes. Leesha was diagnosed in September of 2022 with pancreatic cancer. And since then, she has used her diagnosis for purpose and raising awareness as a patient advocate for the National Pancreas Foundation. And Leesha, we want to thank you for your bravery, for the time you're taking to share with us, to patients and patients' families and providers that are taking care of patients with pancreatic disease. So Leesha, thank you very much.
Thank you so much, just for the opportunity to be able to speak and share. I don't have any slides. I'm just going to kind of wing it because that's the kind of person I am. But like Dr. Conwell said, I was diagnosed September of last year with pancreatic cancer, stage 4. And it was very interesting, yet a relief. A relief because it kind of answered why I had been feeling the way I had been feeling. And just listening to the information from Dr. Yazici, just some of the things that he said were indicators that I didn't even know, and I didn't even know to ask at the time. And I'm like, oh, yep, had that. So just knowing, having the information, and I appreciate the National Pancreas Foundation for this initiative, because I honestly did not know. And I am grateful that I have the platform at Praise 107.9, which is how I got connected to the National Pancreas Foundation. And through my church, shout out to the Bethel Church in Jacksonville, Florida, for being a great support. Pastor Crystal really outlined the fact that, churches are a staple and a foundation for people of color, for Black and African Americans specifically. That's, one of the places we gather. That's where we come together. And so my journey, to me, a little unorthodox, because it was kind of a night and day thing. When I was diagnosed in September, it was kind of a fluke. I'd gone to do a blood test, getting ready to see my PCP. And then all of a sudden, my levels were out of whack. From June, I was a little anemic. September, stage 4 pancreatic cancer. But in that moment, that the doctor told me that I had cancer, God told me healing has happened. And I'm just going to say this. Hopefully you guys get it. I'm not a spooky Jesus kind of person, but I clearly heard God's voice say healing has happened. And that has been the platform, my mantra, whatever you want to call it. That has been the thing that has helped me navigate this journey through faith, through all of the ups and downs, through weight loss and numbers going up and numbers going down. And that is the thing that gives me hope. Because he didn't tell me how he was going to heal me. So whether he heals me on this side of glory or with him, my stance is healing has happened. And so when things look bleak, healing has happened. When I have a great day, healing has happened. And that is one of probably my greatest message to anybody going through anything, especially a health crisis. Finding your faith in frustration, because let's be honest, health challenges can be very frustrating, whatever it is. You stub your toe, you get a paper cut, it's frustrating. Like it hurts and things are out of whack and you got to do things differently. And the process to healing can be frustrating. But if you have a foundation in faith, it gives you something to stand on, to lean on, to fall back on when everything else goes awry. At least that's my story. And I hope that it can be yours as well, because there are times when it doesn't look good. As a matter of fact, on I don't remember the date specifically, but the Friday before Thanksgiving, my doctor called and told me that I have 6 months left to live. Maybe a few more months with chemo. And while that news is devastating, like in that moment, that was really hard to hear. Like, oh, so you got a date for me? That's what you're telling me right now? You got a date. Okay. But once I felt the feelings, I got back to the place of faith. And I said, God told me healing has happened. I understand what the doctor's saying. I understand what my numbers are looking like. I get all of that. But I cannot wallow in that space. I can't just fall back and fall away. I'm a mother. I've got an 11-year-old son, an amazing kid who is at 11 doing amazing things. And I want to be here for every moment. But if I can't, then I want to be able to show my son how good God is, even in the midst of something that's not good. I want to be able to show my friends and my family that it is okay to feel and it is okay to operate in faith. And those two things are not separate. Because sometimes we find ourselves in a space, people of faith, churchgoers, you know, you want to be all hallelujah, thank you, Jesus, or whomever you want to give honor to, and you want to just focus on the good. And that's fine. But when things go bad and when things go awry, how do we maintain? How do we push past what we are feeling on the inside, which we are well within our rights to feel? We are well within our rights to experience all of the emotions and the upheavals and the whatever you got. But get back to a place that says, I can do this. I can go through this. I'm not going to allow the diagnosis to push me down. I'm not going to allow, this situation to take me out. I have to find something. I have to have something that keeps me going, keeps me motivated, because we have to press toward the mark, right? And so I'm grateful that God told me September 23rd, 2020, that healing has happened. Because when when November 17th came along and the doctor said 6 months, I had my moment. And then I got back to faith. And so I know that there are a lot of people who might be going through situations and it is overwhelming. I truly understand what that means. I truly do. But I also understand that for me, there's a purpose in this place. And it's not just for me. If I didn't have the diagnosis, I would not have met Janine Adams, who is the NPF Jacksonville chapter rep. I would not have been connected to the National Pancreas Foundation. I wouldn't have had this opportunity. I wouldn't have had the opportunity to share my story in the halls of Congress. I wouldn't have been, poured into like I am being right now. And so I'm not mad at my diagnosis. I'm not upset about it. There are upsetting times, and I allow myself to feel that. But at the end of the day, what I realize and recognize is that this is an opportunity for me to live out my faith in real time. This is an opportunity for me to share who God created me to be and the message that he gave me, and believe that it's helping someone more than me. I know I'm being helped by the word God gave me. And so for me, my faith is my foundation that allows me to share and share freely and openly without reservation that healing has happened on days that look great and on days that don't. And so my hope and my prayer is that through the information that you have received tonight, and as you start following the speakers and the National Pancreas Foundation, that you'll find what you need for your journey, that you'll find the information to get tested for things and have the information, like Dr. Yazici said, like, hey, I've had some of those things. Ask your doctor about those things. That you find out that your church has a program that can help you do more research about these things. They connect you with a community of people that will not only support you in your health journey just by providing resources, but also to be able to pray for you and encourage you and be with you throughout that journey. And I also hope and pray that whatever space of life you're in, whether it has to do with pancreatic disease or not, that you will walk out your own path to healing, because it has happened for you as well. In whatever area you need healing, you just have to walk out the process. So that's my encouragement to you on today. And I hope that this information has been helpful to you.
Wow. Thank you so much, Leesha. I want to have all of our panelists just please turn your viewers back on your video so we can see you, we can share and talk, and we can really wrap and just talk about this. Your faith walk is amazing. We appreciate you so much. And in my church, we would say, let the church say, amen. She's preached a good word to us. We really appreciate what you're going to do for so many people. You've inspired me, and it's going to help me continue and be fired up to go to clinic and take care of patients that have pancreatic disease. So thank you so much. I want to thank Dr. Bradford, Dr. Yazici. You guys are just amazing. We appreciate what you're going to share with us, and we're going to spend some more. Dawn Baker is on, who is our project manager at the University of Kentucky, our pancreas program we call UK Prime, Pancreas Research, Innovation, and Medical Education. We're just excited to be here with you all. So we're going to open it up for some questions. There's a question about pancreas insufficiency, Dr. Yazici, and I think that's a biggie, because you get that in some patients with the different stages of pancreatitis and cancer. You want to just tell us about that in terms of the diagnosis and treatment and management of it? Turn on your, everyone turn on their mics. Yeah, thank you.
Yeah, you're welcome. Thanks. I think, in regards to pancreatic insufficiency, mainly we are, listening to our patients to see what their symptoms are. These patients who develop pancreatic insufficiency, they usually have oily, foul smelling, sometimes loose stools. So that's pretty typical symptom from patient's part. And we can do a stool testing to look for levels of pancreatic enzymes in the stool. So it's a fecal elastase test, and if it is below certain level, and if the patients are having symptoms, so that's pretty much good enough to make the initial diagnosis and start the patient on a pancreatic enzyme replacement therapy. And I try to put it into the chat box. So National Pancreas Foundation website also has some information in regards to that with an animated pancreas patient. So hopefully that will be helpful. And I saw that there wasn't too much help from a gastroenterology that, it's sad to hear, obviously, as pancreatologists as well as gastroenterologists, but sometimes these diseases, because in this area where everyone has a very focused area of interest, these diseases are treated best in centers with physicians that has the experience, and that's one of the mission of National Pancreas Foundation as well. That's why they created these centers of excellence for pancreatitis and also pancreatic cancer. So anyone who is really having challenges in regards to reaching to physicians or healthcare providers, I advise them to look into NPF website to find the closest NPF Center of Excellence for pancreatitis or pancreatic cancer and try to reach through that road. But if still they are not able to obtain any help, I'm happy to do a search to see whom I can identify and refer them to.
Thank you, Dr. Yazici. This leads us to another question about just nutrition and diet, and you talked about that in terms of you mentioned what are we supposed to eat, and are there special things? I want just to reemphasize something that you said in your lecture. Talk to us about nutrition and diet.
Yeah, it's very important because nutrition, obviously, all those elemental key nutrients are important for our body, as well as it plays a key role in regards to our gut microbiome as well, because those are also metabolized by the intestinal microbiota, and then certain end metabolites are released. They may also have a different effect on our overall health. So it's very important, and especially those patients with chronic pancreatitis and pancreatic cancer, for them to have a really well-balanced diet. With that, what I mean is diet that is obviously good in protein. Part of that could be protein from plants. Part of it could be from animals, but we really have to avoid the animal fat. That is, the fatty food that includes fried food and saturated fats and any type of fatty food. If it is too much, it may trigger your symptoms. So general recommendation to avoid really fatty foods, and we can still consume good amount of proteins that can include some animal proteins such as fish and chicken and sometimes red meat, but using techniques that will not introduce too much fat, cooking them or broiling them or grilling them rather than consuming fried foods. And obviously the supplements are important because patients with chronic pancreatitis especially can have deficiencies of fat-soluble vitamins, and your pancreatologist or the gastroenterologist can check for those in the blood. And if the levels are really low, we can supplement them, because in long term, if they are not supplemented, then you are at risk of developing other diseases related to them, such as bone fractures and fragile bones, and then vision problems and bleeding problems.
Yeah, that's great. And to continue on with the nutrition, so the national, we're putting things in the chat for you to go to the National Pancreas Foundation website, pancreasfoundation.org. There's a lot of great information there. So in regard to nutrition, they have a cookbook that you can download, and it has recipes in it. And this is very, very popular. When Dawn and I are out in our community engagement events, we usually have a colored copy of those. Those go really, really fast. People love those cookbooks. There's a lot of downloads of that cookbook to tell you what to eat, nutritious stuff, just what Dr. Yazici is talking about. So please look in the chat, but go to the National Pancreas Foundation website. You will see the cookbook and things there. So that was great. Thank you so much. So Dr. Bradford, this Choose Healthy Life program is really fascinating. I mean, it looks like it's an organization that can really help us break down some of the barriers. And what are you seeing are some of the barriers that people in the Black community, African American community have with accessing healthcare or going to physicians and providers? What are some of the things that you guys are seeing, and how is this organization helping that?
Yeah, it's really allowing us to have that connection that we need to help our people know better. And, when we know better, we do better. We've been able to connect them with insurance, agencies to help them, because a lot of the confusion with the marketplace and even with Medicare, unfortunately, is not clear. There's no easy button when it comes to insurance. And sometimes, we found that people have an insurance carrier chosen before they have a medical problem. But then when that problem arises, that insurance is no longer sufficient for the issues that they have. Now they've got to wait for a new open season to come in so that they can, pick a different provider. And, sometimes, especially with our senior citizens, it has become so confusing that they just kind of throw up their hands and don't do it. So at a lot of our events, we have people that come in. We've got one coming up this weekend. We're going to have Metro Health there to be able to give them sound information, insurance and healthcare. Also connecting people, it's not just the insured, but then we have the problem with the underinsured. So we've got programs that now we can connect those that are underinsured so that they too can, I think part of the emergency room solution came from underinsured or no insurance, because the emergency room is not going to turn you down. But oftentimes we take something that, maybe is a temporary solution and turn it into a permanent way of doing things. And so getting people to see that we have to do something different has been a real thing that we're working for in this program, helping them to know that different doesn't look the same. If you say you're going to do something different, it needs to look different than what you were doing before. And so we're really excited about, the progress that we're making. We've even here at Christ Fellowship Church in Brooklyn, we've been able to partner with the Mailman School of Public Health. We've got some graduate students. They're doing now some evaluations so that we can have some tangible information to show. For the last 3 years, I've been calling our program Walking into Wellness. And I told them just in a focus group this week, I said, if we've been walking for 3 years, we want to know that we're actually going somewhere. We don't want to just be walking in place. And so, these grad students are, they're doing some surveys and they're doing some focus groups to help us see that we're actually making some progress.
Awesome. Thank you so much. I really want to move into another area here, because it really brings up the issue of trust. And I want you all to start thinking about this as a group. But the question that comes up is, how do I get family members to go back, right, to the doctor if they were initially stigmatized, especially if it wasn't a center of excellence, without being too pushy to my family member? How do I get them to go back to get the care that they need? So I want to start it off with Leesha. What would you say? So they ended up at the wrong place. They gave them some misinformation, or they lost the trust. They don't want to go back to see this doctor. Maybe the doctor was having a bad day or whatever. What would you say to them? What would you say to them?
Well, I because I went through this actually. My first round of chemo ended in January of this year, had scans, and the facility never contacted me again. And I'm like, you guys are the ones who told me I had this diagnosis. Like, what's up? And honestly, what got me back to going, searching for another facility or even doing anything was love. My parents loved on me enough and encouraged me to go, but they're my parents. I'm not trying to hear that. Even at my big age of 44. My friends and family were loving on me so much that I wanted to find something. They didn't, there were some pushy ones, but they loved me into a place that I wanted to do better and really operate in optimal health, whatever that looked like. So that's what I would say from a patient perspective who went through that. It was love that got me to go and find someone else.
All right, now love conquers all. So this is it's just such an important question, and we put it in the chat also, the centers of excellence. And what I would say is that family member call a center of excellence and explain to them this is what's going on, and they probably can have a clinical research coordinator, one of their program managers, or someone, a nurse or a medical assistant in the center of excellence talk to your loved one, and let them know what we have available at the center. And we apologize. We're sorry for your experience that you had here with the healthcare system. And this happens. We know this. You get labs done, you get X-rays done, and you don't get a follow-up. And I'm not making any excuses because it's busy. But you did do the X-ray. You dropped the bill. But what about the information that people need, right? So it's very important that that we do that. So Dr. Yazici, what would you say in this situation? Here I am, and someone says, "Listen, I can't. I listen to your webinar, but I got a family member with pancreatitis, and they don't want to see anybody. We had a very bad experience. And how do I get them back and getting the help? They're losing weight, they're in trouble, but what do I do here?"
I think probably, as a family member, obviously it's someone that you really love and devoted, as Leesha highlighted, just trying to explain that it's best for the patient, the patient itself, but also for the family as well as your loved ones. But also, I guess, try to say that it could potentially be a different experience depending on whom you talk to. And I think that is why it is really important. I didn't spend too much time, but one of the ways that we try to do it, we try to diversify our healthcare, task force. So here in our clinic, we are a minority serving institution, but probably 80% of our, medical assistants or, the other healthcare providers are also very representative. We have lots of Hispanics, lots of, African American patients, African Americans that are working with us. We have some, Asian healthcare workers as well. So I think when it's really a diversified workforce that can really reach out and communicate with patient, really listen and connect, I think in that case, you can really make a difference. Obviously, you have to follow up on task and do what is really needed on your end. But I think making the patient feel like that they are welcome and that, they are in a place where people are really genuinely interested in that. So I think that makes a difference to bring them in.
Okay, so moving further along in this trust narrative, one of the things that's very important is research. Clinical research, translational research, basic research. We have not cured pancreas cancer. We're still in the fight. We have some great drugs that do prolong life. We've got new immune therapy that may provide some of the answers. We have genetic testing that we may be putting into the rubric of earlier diagnosis, and there's a lot of research going on at the NIH in this. But there's a trust factor. There's a problem here in the Black African American community with trusting the healthcare system. them in getting enrolled in clinical trials. And like you said, we need to get African Americans in clinical trials to know what the subtle differences are in their response to chemotherapy, radiation therapy, just because they are a person of color. They're different. People are different. So what would you say, Dr. Bradford, how do we help get that trust reestablished? I mean, I'm sure you're seeing some of this and you're probably getting questions about this.
Yeah, definitely. We actually have had 2 sessions with people at the New York Presbyterian Hospital Research Center. We've had them on our virtual call, just helping people, educating people about clinical trials and research and why it's important for us to be a part of this. And then we've actually had them in the building so that they can come in and talk to people. And I think the discussion really is the first place to start, just helping them to see, having some testimonials. One of our daughters worked for a blood center. And as you know, in the African American community, getting us to go to a blood bank to donate blood is a big challenge. And, just even understanding what she went through trying to recruit people has been helpful for me now in this area, trying to just educate people, to help people to know that, yes, there are some things, we're not denying what has happened in the past, but we can't allow the mistakes of the past to prevent us from a bright future that's ahead of us. So, sometimes we just got to put some things aside, understand that people don't always get it right. And now we've got to move forward.
Fantastic. Great. Thank you so much for that. The history of, the syphilis project, and the Tuskegee experiments and, the Henrietta Lacks situations and things that's that's ingrained in our Black and African American community that we are aware of does keep us from trusting, the medical system, the research community. But we've got to break down those barriers and we got to communicate. And I think one of the things that Dr. Yazici's talking about is having people that look like them, represent them, diversify them. So that will help with some of the trust. And I want to turn to Dawn Baker, who really is on the front line of a lot of things that we do in terms of she's there talking to patients. We talk about engaging, educating, and empowering. And Dawn, what are some of the things that, that you really see patients are asking you when you're there handing out all these pamphlets and things? What are some of the things they're asking you they really want to know about?
The most that I hear is a statement and a question together. And that is what Leesha said, I didn't know. And then the follow-up is this genetic? A lot of people don't know the questions to ask when they get the diagnosis. And I'm really grateful for the pamphlet that we have to give out from the NPF, because it tells you the questions to ask when you're diagnosed with chronic pancreatitis or pancreatic cancer. So that's a good one to give out. A lot of people are appreciative of that. But the question that I hear a lot is this genetic? Should I get checked? And what are the questions to ask?
Yeah. So that's a good question. So Dr. Yazici, you're the medical expert here. So this is a topic that comes up. Are my kids going to get this? Are my brothers and sisters? I mean, what about talk to us about the genetics. There's a lot of research ongoing, a lot of information we don't know. But tell us what we do know right now. But what would you tell patients about the genetics? Is this genetic? Is my family going to get this? Or is my daughter or son in trouble here? What do I need to do?
It's obviously it's a wide spectrum of disease, from acute pancreatitis to chronic pancreatitis to pancreatic cancer, and there could be a genetic basis for it, but it is not the most common cause. So although someone with genetic susceptibility may be at higher risk for developing pancreatic cancer, most of the time, majority of the patients with pancreatic cancer, may not have genetic disorders. Similarly, for acute pancreatitis and chronic pancreatitis, there could be certain mutations that are increasing the risk for both, but majority of the patients actually do not have, as far as we know at the present, that do not have a genetic factor that leads to pancreatitis. The most common causes for example, acute pancreatitis and chronic pancreatitis. 70% of them are because of gallstone disease and alcohol. And that is most often followed by really, really high type of cholesterol called triglyceride. So hypertriglyceridemia as another cause. And there are less commonly seen causes. Sometimes it could be because of a procedure. Sometimes we do it to treat patients. It's called ERCP that can lead. There could be certain medications that are associated with pancreatitis, and there could be certain diseases an individual has, certain autoimmune diseases. If there are there, then such as celiac and diabetes, those patients may have higher risk of, developing pancreatitis. And obviously, smoking is also another factor, and that is associated with increased risk. So that's usually try to look for the most common causes, and you just have to try it, eliminate and see if the patient has this, that, and if you cannot still explain it, there's a good portion of patients we do the genetic testing, especially if they are young, if they have family history, if they have other, autoimmune diseases or potential, diseases that put them at risk.
Yeah. So thank you very much, Dr. Yazici. So as you can see, I mean, he's an expert, but he's at a center of excellence. And so if you're talking with your physician and these questions are unanswered, please go to the NPF Center, find a website, find a center of excellence. You can get these questions answered, because we have to know when to do genetic testing. Genetic testing costs money. All right. Your insurance company may not pay for it, but if you line up, if your physician does the right thing in terms of eliminating other causes and you still have documented pancreatitis, then it's indicated that you get genetic testing, whether it's pancreatitis, pancreas cancer. So this is very important. And also, centers of excellence know if you have a history of breast cancer, they know specific types of breast cancer genetics will predispose you to pancreas cancer. Certain types of colon cancer, colon polyp syndromes, some hereditary conditions can predispose you to pancreas cancer, and you should be tested. This is not routine information that most physicians know, and that's why we have centers of excellence for you to get these answers to these questions. So please log on to the site to get those answers. I feel very strongly about this. You've got to get information. Someone mentioned, thank you for the information. We are excited to provide it. Now, this is a question for Leesha, because this is a patient. She goes, I am so scared with this diagnosis because I've been dealing with this a long time. I was told I had irritable bowel, so my trust is down with doctors, because being treated for irritable bowels for so long has put me in a bad place.
I would encourage you to just really hunker down in your faith. Because my favorite saying, especially since the pandemic, because people showed their whole tail during the pandemic, we found out a whole bunch of extra stuff. And we know that people will people. They're going to be who they are. We didn't know who they were before, but they're going to do things that are unexpected, that we think are unexpected, or they shouldn't do. But that could just be them. It could be the circumstance. We're not putting our faith in that particular experience. We understand that's that person, that's how they operate. Much like, you got friends that act a certain way, how they operate, and I'm gonna tell this friend this thing, or I'm not gonna tell this friend this thing. We just got to find some new friends, got to find some new people. We have bad experiences in other places, and understanding that health is a major thing, but you have to understand at base, they are people. They make mistakes. They have bad days. They might have a bad character. Whatever you want to assign to it, people will people. Now let me find my people. That's kind of how I'm operating.
Awesome. Thank you so much. I do want to emphasize, again, you can contact the NPF, and an email has been put in the chat, and I actually copied it again, because you can just say, look, I need some help. I need to know where to go. I mean, I've got referrals directly from this, being in Kentucky, a lady that was referred from Tennessee up to us in Lexington, Kentucky. So this is active. It works. It's live. It's real. People care. This organization was started by people with pancreatic disease, with pancreatitis, and with the same symptoms, problems, questions that you have that were unanswered. totally unanswered. And so now we've got a central location to help you as advocacy, to help you and to educate you, to empower you to make changes that's really needed. So any other questions? I'm looking in the chat. Any other comments that people may want to make that's on the call? I will say this, Leesha, we can't thank you enough. You know, our patients are why we are here. It's why we're fighting this fight. And I really, and someone actually mentioned this. I was trying to read your T-shirt, and I really admire that. So once in a while, someone amazing comes along, and here I am. And I think we thank God for you, for your comments, and I think this has been our best webinar ever. We actually, well, people don't know, the practice session of this was also just absolutely amazing. And we are just thankful for AbbVie for allowing us to do this. This is more than this is really true love. This is about loving your neighbor. How do we help you get in a better space with your healthcare? So we are thankful, and I'm just very happy that you all took the time to come. And this is being recorded. It's going to be shown to thousands of people. It's going to be on the World Wide Web. It'll be on the NPF site, their YouTube site. So a lot of people will be able to see this. You can drive your patients and family members to this and review it. And we're just thankful. And I want to thank everybody, and Sofal Tan, who is really the maestro. She's the conductor of the symphony that we have when we do this, and we just want to say thank you for all that you do. And she's the one that you're emailing, that's getting information to people. She's making huge differences in people's lives, and we're all serious about pancreatic disease. We want you to be better, we want you to be healthier, and we want to help you. So I'm going to sign off with that. So for anything you want to leave as parting words to us, again, AbbVie, we need you. We thank you. We appreciate you.
No, thank you. I mean, I just want to make people look good. So I will provide everything to make you guys look good. I'm just so grateful for all of you, who just gave up your night to speak. Dr. Conwell, Dr. Yazici, go home. I see that you're in your office. It is like 8:30, like on the East Coast. So grateful for you. Thank you so much. And I will be sending out an email to all registrants with this YouTube link. And then also it's a way for you to get in contact with me as well. Minister Bradford, we keep calling you doctor, you've been elevated. But she's shown you, and also Dr. Conwell, like what a table for the MPF looks like. If you want to be involved, we will provide you with the merchandise. If you can get us in contact with anybody from your community, because I think it's very much the grassroots level that is really going to promote pancreas disease awareness. And also this is a way to reach folks on the national level all across the country in one go as well. But thanks everyone again. And you'll be here with me in a little bit, but thanks and have a good night.
Good night, everybody. Thank you all very much. Appreciate y'all and your time. Thank you.
All right, bye.